Imagine you are like a teenager,
Yeah.
maybe 15 or 16 years old.
Okay, yeah, peak high school years.
Right. And you are experiencing this severe, just completely debilitating pelvic pain every single month.
Oh, that's awful.
It is. I mean, it's the kind of pain that keeps you curled up in bed, missing out on tests, skipping social events. It's basically sidelining your entire daily life.
Yeah, completely taking you out of commission.
Exactly. And when you finally, work up the courage to tell the adults around you, like your parents, your teachers, even your doctors, you're just met with this dismissive shrug.
Right, the classic, it's just a normal part of growing up.
Yes. Or that, everyone gets bad cramps and you just need to tough it out. But we have to ask, what if that pain isn't a rite of passage at all? What if it's actually a measurable physical chronic disease?
I mean, that is a profound and incredibly frustrating reality for, millions of young women.
Yeah.
We tend to view modern medicine as this highly objective science, But when we look at adolescent pain, subjectivity, and these long-standing societal biases, they kind of steer the ship.
The suffering just gets normalized instead of actually investigated.
Exactly.
Well, investigating that normalized suffering is our goal for today's deep dive. We're looking at a pretty pivotal 2020 systematic review.
Yeah, it's a big one.
It's titled The Prevalence of Endometriosis in Adolescents with Pelvic Pain. This was authored by Martin Hirsch, Rima Dillon-Smith, and their colleagues, and published in the Journal of Pediatric and Adolescent Gynecology.
Right. And they gathered just a massive amount of data to figure out what is really going on with teenagers who are experiencing this level of pain.
So our mission today is to kind of cut through all that societal noise, right? We're going to look strictly at the data.
Yeah, strictly the facts.
We want to unpack the real prevalence of endometriosis in teenagers, examine the severe disruptions it causes to their lives, compare the diagnostic tools we have, and honestly, highlight the glaring gaps in medical research.
And there are a lot of gaps when it comes to treating this specific demographic.
Oh, definitely. But before we throw a bunch of statistics at you, let's actually define what we're talking about, because the situation described in this paper is, well, it's baffling.
It really is.
To understand why it's so frustrating for patients, I like to use a biological metaphor. Imagine the lining of the uterus as a specific type of grass seed, right? And it's meant to stay neatly contained in the front lawn.
Okay, I like this analogy.
Right. So endometriosis is basically what happens when those seeds get blown into the garden beds, onto the driveway, into the gutters.
They end up everywhere they shouldn't be.
Exactly. And when it rains, or in this case, when the hormonal cycle triggers menstruation, that misplaced grass tries to grow and bleed everywhere.
Wow.
But because it isn't in the uterus, there's just nowhere for the blood to go. It gets trapped, and that causes massive structural damage, inflammation, and scarring all throughout the pelvic cavity.
And that road tissue, I mean, it is entirely physical. It's a biological anomaly, creating real mechanical problems inside the body.
Right. It's not just in their heads.
Not at all. And to understand why ignoring those mechanical problems is so disastrous, we first need to look at the sheer scale of the issue.
The numbers. Let's get into the numbers.
Yeah, because this isn't some rare 1 in a million anomaly. The researchers analyzed data across 19 different studies.
Wow, 19?
Yeah, compiling information on over 1,200 symptomatic adolescents.
1,200 teenagers. That completely shatters the whole "it's just bad cramps" narrative right there.
It really does. So among the teenagers in these studies who underwent a laparoscopy, which is a surgical procedure to look inside the abdomen, an average of 64% were found to have endometriosis.
Wait, 64%? Over half?
Yes, and depending on the specific study and the clinic's criteria, that prevalence ranged from 25% all the way up to an astonishing 100%.
Hold on, I have to push back on that a little. If we are talking about teenagers getting surgery, aren't we only looking at the absolute worst-case scenarios? Like, a doctor isn't sending a 15-year-old to the operating room for average cramps. So isn't that 64% heavily skewed by who's actually making it to the surgery table in the first place?
That's a really great point. And yes, the clinical heterogeneity across these studies heavily influences that number. The criteria for even offering a teen a laparoscopy varied wildly between the different clinics.
Oh, I see.
Yeah, some hospitals only offered surgery to teens whose pain was completely refractory to medical therapy, meaning, they had tried every hormone, every painkiller, and absolutely nothing worked.
The absolute last resort.
Exactly.
Yeah.
But other clinics had a much lower threshold for surgery. So the pretest probability is high because these are patients already seeking specialized care.
Right.
But even factoring in that selection bias, it still proves that endometriosis is a primary driving culprit for severe chronic pelvic pain in this age group. I mean, it is not a fringe diagnosis.
And we aren't just talking about a tiny speck of disease here either. The study broke down the severity using a 4-stage system.
Right, the staging is crucial.
Of the teens diagnosed, 53% were at stage 1, which is minimal, but 28% were at stage 2, 20% were at stage 3, and 13% were at stage 4.
Which is severe, extensive disease. We're talking deep cysts and dense scarring binding organs together.
Yes, teenagers. We are talking about teenagers with stage 4 endometriosis.
The real-world impact of that disease burden on a developing adolescent is just, it's devastating.
Completely.
The research notes that between 50 and 90% of adolescents report dysmenorrhea, which is the clinical term for severe menstrual pain or chronic pelvic pain.
Right.
And this leads to an average of 19 days per year of educational and professional disruption.
19 days. I mean, think back to when you were 15 or 16. If you missed a full month of your sophomore year, what happens to your math grade?
It tangs.
What happens to your friendships,
Right.
your extracurriculars? You are at the absolute peak of your educational life, forming your social foundation, preparing for your future, and you are literally sidelined for a month every single year.
Yeah. Furthermore, 27% of adolescents report sometimes or always missing school due to menstrual symptoms.
Wow.
The cumulative effect of that absenteeism, I mean, it fundamentally alters a teenager's life trajectory.
So if a teenager is losing weeks of her life to this pain, and we know endometriosis is a highly prevalent physical disease, how is the medical system responding in that moment? Like, why aren't they getting diagnosed and treated immediately?
Well, that leads directly into the societal and medical hurdles that actively delay diagnosis.
The gaslighting.
Exactly. The paper highlights a truly shocking statistic. Diagnostic delays can be 3 times longer for women whose symptoms started in adolescence compared to those whose symptoms started in adulthood.
30 times longer. Just because they are young?
Yes, just because of their age. Physicians frequently minimize, normalize, or simply dismiss the severity of the pain.
That's infuriating.
It is. There's this deeply ingrained societal belief that teenagerhood and menstruation are inherently painful, and therefore the suffering is just an inevitable part of the biological package.
Right, the welcome to being a woman speech. And when a doctor does acknowledge the pain, the immediate response isn't necessarily to look for the disease, right?
No, not usually.
The text mentions that governing bodies like the American College of Obstetrics and Gynecology, ACOG, suggest 3 to 6 months of empirical treatment.
Right.
So basically, a doctor prescribes a combined hormonal contraceptive, like the birth control pill, to see if it helps, without actually doing any diagnostic investigation to confirm if endometriosis is the root cause.
Yeah, and look, empirical treatment with hormonal contraceptives might improve the day-to-day symptoms for some patients, by stopping ovulation and thinning the uterine lining.
Sure.
But the study notes a massive complication. Simply using birth control without investigating further has been associated with a significant delay in the actual diagnosis of endometriosis
Oh, wow.
and potentially higher rates of severe endometriosis later in life.
Let me bring it back to that car analogy, because I think this is where the mechanics of the treatment are super important. Offering birth control without investigating further is basically like slapping a piece of thick black tape over a flashing check engine light.
Oh, that's a perfect way to put it.
Right, you don't have to look at the warning anymore, and maybe the car runs a bit smoother for a little while because, I don't know, you changed the type of gas you're putting in it. But the engine could be quietly deteriorating underneath the hood.
Exactly. And the danger of putting that black tape over the check engine light is that while the hormones suppress the bleeding, that rogue tissue we talked about earlier, it might still be quietly causing low-level inflammation and scarring in the pelvic cavity.
Even while they're on the pill.
Yes. The hormonal contraceptives can mask the outward pain signals, but they don't necessarily halt the physical progression of the disease.
That is terrifying.
It really is. And it highlights a crucial takeaway from the research. Getting a timely, accurate diagnosis isn't just about figuring out which medication to prescribe. It provides something much more profound.
Legitimization.
Exactly. It provides relief, liberation, and the absolute legitimization of their symptoms.
That word is so important, legitimization. When you have been told for years that your pain is normal, or worse, that it's entirely in your head, finally having a doctor point to a scan or a pathology report and say, you have a disease, I mean, that has to be life-changing.
Oh, absolutely. An official diagnosis proves to the teenager, to their family, and to the school administration that the pain is real.
It's physical.
Right, it's a biological anomaly, not a psychological weakness. And that legitimization is the key that unlocks access to targeted support, formal educational accommodations, and tailored medical management, rather than just forcing them to suffer in silence.
Okay, so if surgery is too aggressive for a young teenager just looking for answers, but doing nothing allows the disease to silently progress under the guise of birth control, doctors are trapped.
They really are.
They need a way to look under the hood and legitimize this teenager's pain without actually opening the car. So let's talk about the diagnostic toolkit. You mentioned earlier that the gold standard for diagnosing endometriosis is laparoscopy, but let's be clear about what that actually entails.
Right, because laparoscopy is an invasive surgery.
Yeah.
The patient goes under general anesthesia, the abdomen is inflated with carbon dioxide gas, and the surgeon makes small incisions to insert a camera and surgical instruments. They physically look for and biopsy the rogue tissue.
Wow.
It remains the gold standard because you are literally looking at the disease with your own eyes. But because it requires anesthesia and carries surgical risks, doctors are naturally hesitant to order it as a first step for young, developing patients.
Obviously. And unfortunately, the traditional non-invasive methods adults use just don't work for teenagers.
No, they don't.
Transvaginal ultrasounds or internal physical exams are often contraindicated, anatomically difficult, or just highly inappropriate for young adolescents. That leaves a massive gap in how we diagnose teens, which is where magnetic resonance imaging, MRI, enters the picture.
Yes, MRI is really emerging as a powerful, non-invasive alternative. The magnetic waves create incredibly detailed cross-sections of the pelvic organs without any radiation or internal probes.
That sounds ideal for a teen.
It is. And the paper details that MRI has an 83% to 91% sensitivity and a 98% specificity for detecting deep endometriosis.
I mean, those are really solid numbers for a scan that just requires the patient to lie still in a tube. And the authors actually looked at a specific study, right, by Regab et al., published in 2015, that directly compared MRI to the surgical gold standard.
Yeah, the Regab study is highly illustrative of how MRI can perform in the real world.
Okay, tell me about that one.
So they looked at 220 teenage girls in Egypt who were presenting with severe dysmenorrhea. Out of that group, 22 teens opted to skip the surgery entirely and get an MRI instead. The radiologist reviewed the scans, looking for specific imaging features like localized bleeding or cystic masses. And based purely on the MRI, 77% of those girls were highly suspected of having endometriosis.
77%. Okay. And how did that compare to the girls who actually went under the knife?
Well, in the group that underwent the laparoscopy, 79% were officially diagnosed with endometriosis by the surgeon.
Wow. So 77% suspected via MRI and 79% confirmed via actual surgery.
Yeah, this is good.
That is incredibly comparable. I mean, the benefit of avoiding general anesthesia, surgical incisions, and weeks of physical recovery for a teenager who's already missing school, that is massive.
Oh, the benefits are undeniable, particularly for the physical toll on the patient. However, the study heavily emphasizes the limitations of imaging.
There's always a catch.
Always. This brings up the mechanics of how endometriosis actually presents in the body and why MRI isn't a perfect silver bullet.
Okay, lay it on me.
First, the imaging modalities we use haven't been strictly validated for adolescent populations. But more importantly, we have to distinguish between different types of endometriosis. MRI is excellent at detecting ovarian endometriomas.
Ovarian endometriomas. Let's define what that is for everyone.
An ovarian endometrioma is essentially a large blood-filled cyst on the ovary.
So that's painful.
It is. And it has significant volume, it takes up space, and MRI can easily see that fluid and that mass.
Okay.
But MRI struggles immensely with superficial peritoneal disease.
And peritoneal disease is what exactly?
It refers to flat, superficial lesions spread thinly across the peritoneum, which is the lining of the abdominal cavity.
Okay, so it's not a big cyst.
Right. Think of it like trying to spot a flat water stain on a wall from a satellite image. The MRI technology simply doesn't have the granular resolution to spot something that shallow and flat against the tissue.
Hey, wait, let's do the math on this because I'm realizing there is a massive flaw here. We established earlier that 53% of the teens diagnosed in these studies had stage I disease, right?
Correct.
And stage I is often characterized by exactly what you just described, that superficial peritoneal disease.
Yes.
So if the majority of teenagers have early stage flat disease, An MRI is likely to miss early-stage flat disease. Aren't we risking a massive false negative rate?
The risk is incredibly high.
Wow.
And that false negative scan can easily be weaponized against the patient,
Hmm.
further delaying the true diagnosis.
Right. If a well-meaning doctor orders an MRI to save the teenager from surgery, and the MRI comes back entirely clear because it just couldn't see the tiny superficial lesions,
Mhm.
doesn't that just throw the teenager right back into the it's all in your head category?
Thanks.
That is a nightmare diagnostic catch-22.
It really is. The doctor looks at the scan and says, the imaging is completely clean, physically there's nothing wrong with you, when in reality the scan just wasn't the right technological tool for that specific stage of the disease.
That breaks my heart.
Yeah, the patient loses their path to legitimization entirely because the scan gave a false sense of certainty.
This highlights a massive blind spot in the medical community's approach. We are stuck between a surgery that is too invasive for a 15-year-old and a high-tech scan that might completely miss the early signs of the disease.
Exactly. Which brings us to the final and perhaps most frustrating part of this deep dive.
Sheer lack of knowledge about what to do next.
Yes, the knowledge gap is profound. The paper notes that back in 2013, international recommendations were made by major medical societies to urgently increase research, specifically focused on adolescent endometriosis.
2013, that was over a decade ago.
Right. They recognized this was a crisis. Yet years later, there remains a severe lack of high-quality randomized controlled trials. We just do not have the data.
And the paper contains a startling admission about the treatment itself. Even when a teenager does undergo laparoscopy and the surgeon successfully removes that early stage I peritoneal endometriosis, we don't have strong evidence showing that the surgical excision actually improves their overall quality of life in the long run.
It's true.
We don't even know if cutting it out alters the natural progression of the disease as they age.
We need coordinated international efforts to develop adolescent-specific clinical protocols. Right now, the medical field is largely operating in the dark, treating teenagers as miniature adults.
But they aren't.
Exactly. Their disease presentation is actually quite different. Teenagers generally present with earlier stage disease, and their social, educational, and developmental needs are entirely distinct from a 35-year-old patient.
Right. If we don't even know for sure that surgically removing the tissue helps them long term, how can a doctor ethically advise a 15-year-old and her parents on what to do next?
Pediatric gynecologists are walking an impossible ethical tightrope every single day.
I can imagine.
Do you perform an invasive surgery on a child just to legitimize the pain, knowing the surgical removal itself might not offer a long-term cure?
Right.
Or do you prescribe empirical hormones that might mask the symptoms but allow the disease to progress silently for decades? Without adolescent-specific research, doctors are forced to make educated guesses rather than relying on robust, evidence-based medicine.
Wow. So, to summarize the journey we've been on today, we're looking at a measurable physical disease, endometriosis, that is highly prevalent in teenagers suffering from severe pelvic pain.
Yes.
It is massively disruptive, costing these young women weeks of their education every single year. Yet their pain is frequently dismissed by adults, leading to diagnostic delays that are 3 times longer than what adults experience.
3 times longer.
And while non-invasive tools like MRI offer a promising step toward proving their pain is real without subjecting them to surgery, those scans aren't perfect. They frequently miss early-stage disease. Ultimately, the medical community desperately needs tailored, high-quality research to figure out how to accurately diagnose and safely treat these young women.
That sums it up perfectly. And to put the urgency of that needed research into perspective, I want to leave you with one final thought to ponder.
Okay.
The study mentions that endometriosis costs society nearly $50 billion annually in the United States alone.
50 billion.
Yes, and that staggering figure factors in direct healthcare costs, massive losses in productivity, and systemic absenteeism.
Wow.
Now, if this chronic disease is derailing so many young lives, taking them out of the classroom for a month every year, and costing the economy billions of dollars right at the start of these teenagers' productive lives, why hasn't this sparked a massive public health mobilization in our schools?
That's a great question.
What if school nurses and educators were systematically trained to recognize these patterns? What if those 19 days of missed school weren't flagged by the administration as truancy or brushed off as normal period pain?
Right. What if we actually paid attention?
Exactly. What if, instead, the education system treated that specific type of absenteeism as the very first critical symptom of a chronic physical disease?
Wow.
If schools actively connected those dots, the education system could actually become the front line of women's health care, bypassing years of medical gaslighting and delay before the check engine light even has a chance to burn out.